Welcome back to another episode of the NRG Oncology Podcast. I'm joined by my co-host, Stephen Chun. In previous podcast episodes, we've had a chance to hear from NRG leaders in surgery, gynecologic oncology, and in radiation oncology. So we thought it was high time to talk about the medical oncology part of the magic sauce of NRG. So today we welcome Dr. Corey Langer, who is the Director of Thoracic Oncology at the University of Pennsylvania, as well as chair of the NRG Oncology Medical Oncology Committee.
Dr. Langer has had a storied career in medical oncology, and his NRG career started long ago with the Legacy RTOG group. I've had the pleasure of working with him in the Lung Core Committee, where we frequently call upon his expertise to develop our multidisciplinary trials. Dr. Langer, I know this might be a basic question, but could you just briefly give us an overview of what a medical oncologist is and how the field of medical oncology evolved? My 97-year-old grandfather, who I've mentioned before on this podcast, actually is a medical oncologist and tells me how far they've come with this new thing that they called chemotherapy in the 1970s. It's really hard to believe how far medical oncology has come today with options like immunotherapy, targeted therapy, and CAR T cell therapy.
It certainly has evolved. First off, I want to thank you for having me, and I hope some of the, reminiscences and thoughts going forward will be useful to your audience. I started out in the mid to late 80s. I finished my fellowship in 87. And at that time, yes, that new thing called chemo was really all we had when it came to systemic treatment. In fact, some of our colleagues, and they tend to be a bit more vulgar in that era, would refer to chemo, BEMO, REMO for the three major modalities that really applied to oncology for systemic treatment, radiation, and surgery. And you've got to remember that chemotherapy in that era, or at least systemic therapy, was highly toxic and not terribly effective. And there was tremendous efforts at trying to readapt and reconfigure treatments so we could make them less toxic and perhaps a bit more effective. But to be honest, I think for a good 10 to 15 years, it was akin to rearranging the deck chairs on the Titanic. It was really during this era that we learned how to integrate systemic therapy, at that time chemotherapy, with other modalities, particularly radiation. And that was the dawn of what I call combined modality, concurrent chemoradiation across the board in most diseases, most specific cancers, showing superiority to either modality alone or what considered to be asynchronous or sequential chemoradiation. But again, we were still stuck with chemo. And it's really been in the last 20 years that the revolutions occurred. Rather than calling it chemo, I think we really have to use a different rubric, and that's systemic therapy. Chemo is only one part of that. It's still a cornerstone of most treatments. But in the early aughts, and certainly over the last 10 years particularly, we've seen the emergence of targeted therapy, of new agents, mostly oral agents that specifically work on genetic abnormalities within specific patient tumors. And some of these are disease specific, but many are tumor agnostic and biomarker specific. So we've seen as well the emergence of drug approvals that cut across diseases that aren't specific to lung cancer or breast cancer or colorectal cancer. And I think our biggest challenge, particularly in the context of the NRG Cooperative Group, is figuring out how to integrate these agents with other modalities, particularly with radiation going forward. In the last 10 years, we've also seen the emergence of immunotherapy. The emergence of PD-1 and PD-L1 inhibitors, CTLA-4 inhibitors, has completely revolutionized practice. We've taken diseases like melanoma, which were totally incurable before the turn of the century, and are now seeing, even in the setting of systemic distant metastases, 30, 40, 50% long-term survival rates. We're seeing that as well, maybe not to the same extent, headway we were making with non-small cell lung cancer. Folks with metastatic disease who do not have a specific oncogenic driver, who are treated with PD-1 or PD-L1 inhibitors, either alone or in combination with chemotherapy, 20, even 30% 5-year survival rates. This is unprecedented, and it's really exhilarating when you think about our prior experience with just chemotherapy alone. It's been a really exciting time to be a medical oncologist and to be part of this revolution in therapy. It certainly has crushed any thoughts of retiring soon.
You've had a long and fruitful career with RTOG and then NRG Oncology. And many of us are glad you haven't retired yet and look up to you in the field as a role model and as someone who guides us in success in oncology. Could you tell our audience about your career in the NCI cooperative groups and what sort of advice you would give to new investigators embarking on a career with NRG Oncology?
Absolutely. Happy to. My career in the cooperative group, specifically in the NCI sponsored groups, really began with one of NRG's legacy groups, the R of NRG, and that's RTOG. From the beginning of my fellowship, I had a major interest in combined modality and figuring out how to integrate chemotherapy with radiation, particularly in locally advanced lung cancer. You have to remember back in the 60s and 70s, our standard treatment for locally advanced lung cancer was radiation alone. And our 5-year survival rates were atrocious. In the 80s and early 90s, we realized that if we gave chemotherapy prior to radiation, we could up the ante, that we could double survival rates. They were still abysmal, but they were better than what they had been historically. But we knew that radiation and chemo could synergize. And so my early efforts, first as a fellow and then as a junior attending, was to look at this approach initially at my primary workplace at Fox Chase Cancer Center at the time. And we saw some success. We saw a lot of toxicity, but we also observed long-term survivals. But you can only do that on the small scale when you're doing individual institution studies. So it was quite clear that to really determine just how much benefit we were seeing, that you had to do this on a much larger scale in the context of randomized phase 2 and phase 3 studies. And that's really where the cooperative groups maintain their lead and their importance. The goal of improving survival, reducing the human burden of cancer by integrating different modalities together. And certainly that was the theme of RTOG, and it was a perfect venue for me to start testing these approaches. Wally Kern, my radiation oncology colleague at the time, and later the chair of RTOG and then NRG, worked with me directly. We created a phase 3 study called 9410. Very, I would say, antediluvian by today's standards. We were looking at full dose cisplatin, older drugs which are really off the scene, vinblastine, etoposide, which we still use, and trying to figure out how to give that with radiation, whether sequential therapy was sufficient or whether concurrent therapy in various formats might be better. And that study actually was a trailblazer. It took many years till it was finished and many years till it was published. But it proved conclusively, along with other contemporaneous trials, that concurrent chemoradiation was superior to asynchronous chemoradiation in the management of locally advanced non-small cell. That study could never have been done except in the cooperative group. RTOG, NSABP, and GOG integrated forces as part of an NCI initiative. And I think all three groups bring their particular strengths to this, what many at the time considered a shotgun marriage, but I think it's been a lot more than that, because we have unique approaches that really complement each group. And I've actually witnessed how that has come together as originally the vice chair of RTOG, the chair of the Medical Oncology Committee, and now the co-chair of the NRG Medical Oncology Committee since its inception. It's been a joy working with legacy members of both GOG and NSABP as we really continue our focus on combined modality therapy, and also specifically combined modality therapy in malignancies that affect women. As for getting involved, I think it's a 3-word message. Don't be shy. If you're developing a concept, say you're a junior attending or even a fellow at a specific institution, ask those who are already involved in the cooperative groups, can I come to a meeting? Can I be a fly on the wall and at least observe? Eventually, if you're interested in clinical trials, you really need to be a clinical trialist, I think, ultimately, to get fully involved in the group. You put together your concept. Our charge, particularly my charge at this later part of my career, is to make sure that new talent is properly nurtured, that we get new blood, that they get involved. So it works both ways. We have a major initiative to make sure that protocols have junior and senior principal investigators, so one can lean on the other and vice versa. Present concepts at meetings. The medical oncology or radiation oncology chairs of each committee will tell you if this has already been done or if it's at least initially worthy. And you'll get valuable feedback, criticism, but again, nurturing criticism in terms of how to go about protocol development. There are other ways to get involved, secondary analyses of existing studies. Stats group and publications committee are in charge of many of these efforts. And also to help out with a lot of the grunt work in terms of auditing and making sure the case report forms are completed. That's what I did initially. I was the chair of the Medical Oncology Quality Control Committee, which existed at the time. It no longer does, before I became the chair of the actual Medical Oncology Committee. This is the necessary work that needs to be done to make sure protocols are run efficiently and properly, that we adhere to guidelines and eligibility criteria. As the Med-Onc chair, I've both at RTOG and now last 10 years in NRG, that's really the only committee where we can have a cross-pollination, a cross-fertilization amongst the various disease-oriented groups. We are united in that we are dealing with systemic treatment, and many of the agents we use are identical.
To our audience, I just wanted to emphasize really how central of a role Dr. Langer has played in the concurrent chemotherapy revolution. I think a lot of people don't realize that in the 1990s, talk about concurrent chemotherapy, people thought it was going to kill everyone from leukemia or from pneumonitis, and really none of that ended up being true. But I'd also, Dr. Langer, like you to elaborate a little bit on another area that you have been part of the effort to change the paradigm in lung cancer. And that has been the immunotherapy revolution, but specifically challenging the paradigm of the need for chemotherapy. Could you speak a little bit about challenging the we always presume you had to have chemotherapy up front for lung cancer, but now moving towards, patients just getting immunotherapy up front?
There's really two separate questions there. One is the notion of combined modality, which was really my emphasis back in the 90s. It was one of the unique approaches that really hadn't been properly tested before then. And then, of course, the more modern era, how immunotherapy, CTLA-4 inhibitors, PD-1 inhibitors, PD-L1 inhibitors integrate into that approach. I'll start with the former. You're absolutely right. There was a tremendous fear factor when it came to, particularly to concurrent chemoradiation. And some of those fears were realized, not so much fatalities or leukemia, but a fair amount of local toxicity, particularly esophagitis, to some extent pneumonitis. And again, I am speaking in my narrow realm as a thoracic medical oncologist. Other organ site-specific toxicities were seen in other diseases. For instance, with anal, rectal, or cervical cancer, you'd expect to see a fair amount of GI toxicity or bladder toxicity. But the principles still apply. How do we improve outcome? How do we improve the therapeutic index, reduce risk, and expand the benefits? And really, that was the focus of the first 10 to 12 years. And I think we learned slowly over time. We learned that lower doses of chemo probably worked as well or better than full dose chemo, that full dose chemo, if it was given with appropriate treatment breaks, still had a benefit primarily locally, but also systemically. We looked at various approaches to reduce the toxicity. And going forward, I know some of our committees, particularly NCORP, is focused on PROs. The big challenge now is integrating some of our newer agents with radiation or chemoradiation. And I wouldn't say we've come to a dead end, but we've certainly met some obstacles. Immunotherapy has really become part of the standard paradigm. The Pacific trial in thoracic oncology and locally advanced non-small cell with durvalumab given after the completion of chemoradiation, and patients whose disease had not progressed and did not have serious toxicities has improved survival rate by at least 10 to 12%. Still inadequate, but that's an 8-fold improvement over just the course of 30 years. The big challenge, and here I think we may be running into a roadblock, is whether we can give immunotherapy concurrently with chemoradiation. As for systemic treatment, I had the privilege of being the co-chair, and this is outside of NRG, in a industry-sponsored Merck trial looking at concurrent immunotherapy, in this case pembrolizumab, with combination chemotherapy, pemetrexed and carboplatin, in advanced metastatic non-squamous non-small cell. I know that's a mouthful, but that's probably the lion's share of advanced non-small cell patients that we see. These are folks without obvious oncogenic drivers, still about 60-70% of our population. And in 2016, I had my 15 minutes of fame at the ESMO plenary session presenting a paper looking at response rate and PFS for that combo compared to chemotherapy alone. We actually observed a doubling of response rate from about 25-27% to well over 50%. We saw 5 to 7 month improvement in progression-free survival. This is very heady data. Frankly, it exceeded my expectations. And this approach now, thanks to phase 3 trials that I participated in but didn't run, has become the standard. Advanced to either recurrent or metastatic non-squamous non-small cell. The use of checkpoint inhibitor with standard chemo can lead to 5-year survival rates of 20%, and that goes up to 30% in those who have high levels of PD-L1 expression, really the target of immunotherapy. And we've also observed that even with immunotherapy alone, pembrolizumab in this case, but other drugs, ipilimumab, atezolizumab, long-term 4, 5, 6-year survival without the necessity of chemo. Now, that's only about 25 to 33% of all our patients, but that's still a significant number. And these are folks now who, I don't know if they're cured, but they're certainly acting like they are cured. And still a minority. We still need to do a lot better. But to be blunt, I could not have envisioned this back in the 90s or even the early aughts at the beginning of this century. So it's been a really exciting time, a very gratifying time when it comes to seeing the advances that we could have only dreamt of back in the 90s.
I think looking backwards sometimes really helps us consider what might be next in the future as well. So, aside from your specific work in lung cancer, can you speak to the work as chair of the NRG Medical Oncology Committee? What are your goals and strategies there, both short and long term, for medical oncology within NRG Oncology?
The Medical Oncology Committee, and I'm the co-chair, actually. Deb Armstrong is the other co-chair, and I think we serve the group equally. It's really part of the major organizational subcommittees of the NRG. We're not a disease-oriented group, so we act in consultation and collaboration with most of the other committees. And here again is the necessary grunt work that really is involved. Our goal is to lead to a cross-fertilization of ideas amongst the various disease-oriented committees. As I mentioned earlier, it's the only venue where medical oncologists from other committees can get together. We are focused in particular on protocol management. We have sub-chairs. Judith Smith, for instance, is the chair of our pharmacy subcommittee, and she has really done yeoman's work in looking at simplification of clinical trials, of coming up with streamlined, reproducible templates that can be imported from one trial to the next without reinventing the wheel each time, approaches toward biosimilars, how to handle our ubiquitous drug shortages that keep coming up, and whether there are appropriate substitutions that we can make in clinical trials. The use of herbal and nutritional supplements, how to handle that, whether placebo controls are appropriate in certain trials. The other subcommittee now, which is the immunotherapy subcommittee, this is headed by Susanna Ulahanen. And again, with the advent of immune therapy, so really a tsunami of agents that come along, we need to better understand their mechanism of action, the potential mechanisms of resistance, how to integrate these agents with other systemic approaches, with chemo and other immunotherapies, and also figure out how to integrate them with radiation. As I mentioned earlier, there may be major obstacles. So her charge is to come up with that. We meet twice a year, generally virtually before the major meetings, a 2-hour meeting. It features CME. In the context of an energy meeting, we have disease site medical oncology updates. We usually do that in the context of ASCO. So we ask our GYN, head, neck, brain, GU, GI co-chairs to present the latest and greatest clinical trials, those that made the plenary sessions, those that will ultimately prove practice changing. The crosstalk, the cross-fertilization between practitioners of all stripes, I think, is absolutely critical.
So on that note, I wanted to ask you something that I think will be of interest, not just to clinicians listening in, but really everyone out there. And that is, what do you see as the biggest advances and opportunities in medical oncology in the pipeline over the next, say, 5 to 10 years? There's so many patients who desperately need better systemic therapies, which I regard as the backbone of treatment for many cancers, certainly any kind of metastatic cancer. What kind of hope can you give them?
Things have changed. Things have really improved radically. We had debates back in the mid 90s. Should we even treat lung cancer? Not second or third line, but first line. Last 15 years, things have changed. We have targeted therapy. They introduced their own unique side effects, diarrhea, skin rash, in some cases pneumonitis. But we are observing response rates, not 30 or 40%, but 60, 70, 80% in thoracic malignancy now in patients whose tumors harbor specific oncogenic drivers, mutations and fusions that are unique to the tumor. These are not hereditary, they're not germline, but somatic. They're found specifically in the cancer cell and generally not elsewhere in the body. In retrospect, I probably had patients in the 80s or 90s who had these oncogenic drivers, but we didn't know about them. The majority of our patients with advanced or metastatic disease back in the 90s succumbed within a year. That is far less common. I wish I could say we're curing more of our patients, but observing 2, 3, 4, 5 year survival is increasingly the norm, not the exception. And that is thanks to both targeted therapy and in the last 10 to 12 years immunotherapy. I'm sure you've seen, Steve, and certainly I've seen folks who've gone through systemic treatment. They got 2 years, maybe more, of systemic treatment. They still have a fair amount of what I call schmutz on their scans, things that look like tumor, but they're not changing. They're just sort of sitting there. They look dormant. The immune system is being effectively marshaled to contain, control, and I believe eradicate tumor cells. The ghost of those cells, the scar tissue that's left behind, can sometimes trick us into thinking that there's persistent disease. Eventually, in many cases, we get a PET scan, lo and behold, nothing lights up, even those abnormalities that persist on CAT scans. So within the last decade now, certainly since about 2015, I have at least a couple dozen patients treated with immunotherapy who are either on or off treatment, mostly off treatment, who are out at least 4 to 5 years. And although I don't want to get ahead of myself, they are acting cured. The irony is they view their oncologists and my staff, my NPs and my nursing staff, as their internists. And I am not a cardiologist. I am not a pulmonologist. I'm an oncologist. So we often get asked to help out with other conditions that are really not in our bailiwick. And I think both internally within oncology and also broadly for all our patients, the Hillary Clinton adage, it takes a village, really applies. Multidisciplinary management is the key to managing these patients, certainly within the realm of their cancers, but also broadly within their entire health. No single person can manage an individual patient alone.
One other thing that we wanted to ask you, and maybe this is a little bit tongue in cheek, but also truly curious to have your thoughts on this. Do you have any pearls of advice for a study team discussing systemic therapy as part of a clinical trial? Are there any common misconceptions or topics you feel are misunderstood when people talk about systemic therapy? Any pet peeves or pitfalls that your radiation oncology, surgical, and gyn-onc colleagues can be sure to avoid?
Great question, and a little bit tough, but not that tough. When it comes to clinical trials, specifically when it comes to patients, and really that's the name of the game, we don't make any progress in oncology without enrolling our patients on clinical trials. And I tell them that. I tell them every single thing I'm about to mention or offer or suggest, or recommend, is based on clinical trial work. I have not pulled any of this out of a hat. So to go on a clinical trial is partly altruistic, but regardless, outcomes are generally better. There was a study done back in the early aughts that looked at outcomes, and those who were in the control arms of randomized clinical trials, and they frankly did better by about 10 or 15% than those who are just treated in the real world. The same treatment, same stage, same approach. So clinical trials, I believe, not only benefit science, but they benefit patients across the board, whether they're on the standard arm or the investigational arm. And I will quote that work to at least try to convince folks to consider enrollment in a clinical trial. The other emphasis, and I think we all do this, I make it clear that they're not guinea pigs. People hear the term clinical trial and they think we're just experimenting. And well, that's obviously not the case. But unfortunately, particularly in the US, we have a legacy of experience back from the early 1900s, the mid 1900s, where that was the case. The Tuskegee experiments, where they actually injected African American prisoners with syphilis and then watched the natural disease without intervening. I can't think of anything less ethical, at least in the context of the United States. Certainly more unethical things were done in Europe during the Nazi period. Well, unfortunately, that legacy lives on, and some folks think that's what we're going to do, that we're not really taking their interest primarily. And I rapidly disabuse individuals of that notion. I also make it clear that at any point you can bail out without prejudice to your subsequent treatment. And that's spelled out in virtually all our clinical trials, but that point really needs to be pounded home. When it comes to lung cancer, I tell patients, ask questions, don't be bashful, write them down. In fact, I welcome it when they write them down, because I can write the answers down and then get a copy of that and throw it in the chart. And I've remember what I talked to them about, and B, I have the documentation. So telling both patients and their family members to put everything in writing is quite useful. I'm not bashful or shy about having them record. I tell them don't record while I'm doing a physical exam, but when it comes to actually looking at the films and going over their disease status, record away. I realize that patients are often caught like deer in headlights when you tell them they have a new cancer diagnosis, or that their cancer is starting to progress. And recording at least captures the information that they may be too anxious to process at the time of bad news. So, and I think as clinicians, we should encourage that. I know some clinicians feel very worried about that or self-conscious, but that's something that we need to abandon. The other issue that comes up, and this has less to do with patients and more with our peers, we need to do a better job communicating the advances that have occurred. There's a certain degree of therapeutic nihilism that exists amongst many of the other subspecialties. I still encounter pulmonologists who make a diagnosis of metastatic non-small cell and basically tell patients to get their affairs in order. That's absolutely inappropriate. It might have been appropriate 30 or 40 years ago, but it's not appropriate today. So educating our peers, particularly those who do not work in oncology, is imperative and really needs to be a focus. We need to spread the word, the good news that we are doing better. Other pearls, one of the most challenging questions comes up when patients ask about prognosis. And, none of us knows. We can quote a median survival, but patients will absolutely glom onto that number, and they'll think that that's their expiration date. I've seen this time and again. So-and-so said I had 12 months to live. Well, tomorrow is 12 months. Am I going to keel over tomorrow? I mean, of course not, but they don't understand the concept of median. So when it comes to that question, I usually give two answers. I give worst case scenario and best case scenario. The worst case scenario is, treatment doesn't work or you choose not to get treatment. Here's the estimated survival. And unfortunately, frequently it is less than 12 months. But then I give the best case scenario if treatment does work. And then in most cases now, we can realistically and honestly answer your survival can be years, many years. Back in the 80s, I couldn't give that answer. But in 2024, I can. And I said somewhere in between those two extremes is reality. But I promise you this, if the chips are down, if we're exhausting treatment, if you're not up to further treatment, I will let you know. I will, I'll be upfront with you, and then we will plan accordingly. But there's no need to wrap ourselves in defensive nihilism. Optimism, I think, still helps quite a bit. Hope is beneficial until things truly become hopeless. And then even then, we hope for the best. We want pain control. We want comfort. There are ways to improve upon that as well. So It's been a wonderful career. I figure I have at least another 4 or 5 years left, maybe more, maybe not, but I wouldn't change anything for the world.
Well, Dr. Langer, I really want to thank you for all this insight. And, before we finish up today, I actually wanted to speak a little more about Tuskegee since you bring it up. One of the people when I was a medical student who was a mentor of mine, who I really looked up to as a symbol of ethics and integrity was Dr. Irwin Schatz, who blew the whistle on the Tuskegee
Mhm.
experiments. Dr. Schatz was a professor. He was chair of internal medicine for some time at the University of Hawaii. And really, I've long felt that he should have been considered for something like a Nobel Prize because his efforts to blow the whistle on that sort of thing led to such enormous reforms and oversight over clinical research in this country that something like that would never happen again. And there's just so many layers of oversight with NRG oncology. Maybe another podcast will talk about our safety oversight, our patient advocates. In fact, those podcasts are planned. But again, thank you for joining us, Dr. Langer. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily represent the views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.